Well, good morning, good afternoon. My name is Joachim Florer, and I'll be presenting this seminar or webinar, which is our second one for this year, the International maintrac Online Forum. We do that every 3 months, and I'm glad you could join us. There will be a recording made for this webinar and be available for viewing at a later stage. The special guest is Professor Pachmann, who most of you know. She is the founder of the maintrac system and the chief scientist of laboratory Pachmann, who is conducting the testing and the research. So today the topics are fascinating and I'm looking forward to the presentation. What happens with circulating tumor cells during therapy? Do they go up? Do they go down? Does it mean anything? Does it correlate with long-term outcomes? So we'll be starting with the presentation, 2 case presentations by Professor Pachmann. So please, Professor Pachmann, looking forward to your presentations.
Yes, hello everyone. We are, as Dr. Florer mentioned, doing our second forum this year, and we want to show how circulating epithelial tumor cells can help to register and to see how therapy works, and specifically today during the radiation therapy and what the consequences of these changes are and how they could be hopefully in the future used to modify and to adapt therapy. I will start with the common known features that tumor can seed cells into the circulation, and some of these cells can survive and settle in distant loci and then can grow into metastasis. Our approach to detect those cells in the peripheral blood are fluorochrome labeled antibodies against surface antigens of the circulating cells and then make them visible by fluorescence. Our approach is to get uncoagulated blood from you or your patients and then lyse the red blood cells, stain the epithelial cells, which are most probably tumor cells, with green fluorescence, and then we can put them into 96 well plate and let the microscope go over all the wells, and then it presents us with these cells, which are green fluorescent, and then we can design trajectory of these cells over time. What these cells are looking like, the microscope provides us with a gallery, and the cells that have a nice nucleus and a green staining, which can be quite different, are the living cells. If the cells are in the process of dying, the membrane becomes permeable and red fluorescent dye can enter the nucleus, it's propydium iodide, and thus we can differentiate living from dead cells. This is important because we believe that only the living cells are able to further migrate and form metastasis. The counting makes it possible to monitor therapy and to directly observe tumor activity of the tumor burden which remains in the body, even before metastasis can be detected by imaging tests. Here I would like to ask if any questions forwarded. Nothing? Okay.
There are no particular questions. I think they'll be
That's
coming,
the known
they'll be coming
facts, yes.
soon. Yes.
Yes. Okay, I will go ahead. So this is a case report 1, where we also did monitor the circulating tumor cells during the course of treatment. This was a small tumor, CT1C, but G3 means rather aggressive. Also, the Ki67 is borderline high. It was a tumor which was estrogen and progesterone positive, HER2 positive, and it was diagnosed in 2018 by punch biopsy. It was treated subsequently with neoadjuvant treatment before surgery. There was an additional antibody therapy with trastuzumab and pertuzumab combined, and in December the surgery was performed. Subsequently, as commonly applied, between January and March 2019, there was adjuvant radiotherapy applied, which is always given after breast conserving therapy, or which should be given according to the guidelines after breast conserving therapy. Subsequently, after radiotherapy, the patient was treated with aromatase inhibitor, anastrozole, but which was discontinued after 4 weeks due to intolerance. And the therapy was continued with exemestane instead. Here is the course of the trajectory of the cell numbers during therapy. So during neoadjuvant therapy and surgery and radiation therapy, the cell numbers decreased, they remained stable, even during aromatase inhibitor therapy, and the patient, although aromatase inhibitor therapy was stopped, is still in complete remission. So if there's any questions here.
I think I might repeat one of the question, which is not an uncommon question. What is the aim of the therapy? Do you want to achieve count of 0? Does it mean that's been effective? Or what is the aim of these cells? What is the aim in the numbers of the cells?
Yeah, the aim of the therapy is to eliminate all tumor by neoadjuvant chemotherapy, surgery, and radiation therapy. But our observation is that even after all these treatments, there are still cells present in the body. They can be dormant cells and will no longer be important for the tumor development, but they can also be active. And this is reflected by the increase in cell numbers during different parts of the treatment. Is this?
Yeah, I think we can probably come back to the cell number changes over time. Yeah. in a minute. But is it acceptable, or is it well known that everyone who has had a malignancy will have these cells present in the bloodstream forever? And what does that mean?
According to our results and according to our experience of 15 years of therapy monitoring, we always find some cells present even after years. And this is compatible with the observation that in breast cancer, there can be relapses even after a long time after the first diagnosis, which can be up to 30 years. It's the question whether then under certain conditions, tumor cells can be reactivated. That's not known yet, but in our experience, as long as the cell numbers remain low and do not increase, even if there are some cells present, this is a good sign. And we will give the results at the next webinar. Okay?
Thank you.
So this is now case report 2. And this was a patient with a breast carcinoma of the left side, which was initially diagnosed in 2014. It was a relatively large tumor, TNM classification CT2, and it was triple negative and G3. It was treated with neoadjuvant chemotherapy, and as frequently in triple-negative tumors, a pathological complete remission was achieved after 12 times paclitaxel carboplatin, but there was still one lymph node present. In July, after the end of the neoadjuvant treatment, surgery was performed and it could be breast conserving. So this is the number of cells during this treatment, and it can be seen that until surgery, there was a nice decrease also of circulating tumor cells, and it remained low even after surgery. She received from August to October 2014 radiotherapy, and in May 2015, still, although all therapies had been performed, there was suspected asymptomatic brain metastasis. So here we can see that after surgery, during the time of radiotherapy, her cell numbers went up steeply, and due to this steep increase, although there was no indication for any further imaging, she requested a PET-CT because she was afraid she had to pay it herself, and the asymptomatic brain metastasis was detected. Is there any question?
I think the question currently, which has been posted, is, you see these number of dots. So how frequent would you suggest the testing should be done, the CETC count, during the therapy and afterwards, even in long-term remission? How frequent is the test to be done?
We usually recommend test before neoadjuvant therapy, at the end of the neoadjuvant therapy, before surgery, and it can be to see how the neoadjuvant therapy has been working. It can be done after surgery because sometimes after surgery cells are released to control for this release in cells, and in this case there was radiotherapy performed, and the test was done during radiotherapy, but this was on the request of the patient. But in triple-negative tumors, now it has been shown there is still a high risk of relapse for the patient, so there are additional treatments now applied, and then it would be meaningful to do this before and after this subsequent treatment.
Would it be fair to say, if you find an increase in number of the cells, that you want to monitor more closely to see where that is going, and then helps with the interpretation of that? And if the numbers are in the long-term monitoring are low, then the frequency of that can be adjusted to be less often.
Yeah, that's fair. That would be,
Yeah.
we do recommend also in our reports if the cells remain low.
Yeah.
Okay.
You.
Indeed, the PET, this brain metastasis, or the assumption that there is a brain metastasis, this metastasis was removed by surgery in June 2015. But this was a somehow tragic case because the patient wanted to do proton irradiation and she was not admitted. So she wanted to absolutely to do this, and she collected money from her relatives and from her friends to pay privately for this proton therapy. But in the meantime, there was a recurrence of the brain metastasis during this time. As you can see, there was a nice decrease in cell numbers after the metastasis was removed by surgery, and then there was this nice decrease, but cell numbers came up very rapidly again. She then could do the proton therapy in Munich, and it was observed that the brain metastasis was in regression. She did several approaches: immunization, vaccination, whole body hypothermia, but in April 2016, the MRI showed that the metastasis was in almost complete remission, but it did not completely disappear. So due to this long time waiting for the proton therapy, the metastasis was regrowing, and then after the therapy, it was in regression. So you can see that the proton therapy here led to a nice decrease, but again, the cell numbers increased again. And even with these repeated measurements of hypothermia and natural therapies, the metastasis did not disappear. So is there any question?
There was one question about the therapy itself. What kind of immunization was given at the time? Are you aware of that?
No, I'm not.
Okay.
But I could look up at this again.
Yeah. Often, I mean, that's just my comment. A lot of therapies in immunization therapies are dendritic cell vaccines in Germany. That's commonly used, but it might be good to find out specifically.
Yeah. It's possible that it was exactly this, the dendritic cell immunization.
I have a question which is often, being asked about these brain metastases or even possible brain cancers, where the blood-brain barrier is either, damaged or it's still intact. How come that cells in the peripheral circulation are reflective of what is happening in the brain? What is the thinking around that? How does that work?
I think it's exactly what you said. There is a damaged blood-brain barrier, either due to the growth of the metastasis, or due to surgery, or due to irradiation of the brain. We often can quite well monitor the therapy and see how cell numbers decrease after the different manipulations. But this depends on the individual patient.
Would you expect to see some peripheral tumor cells, circulating tumor cells in primary brain cancers, intracranial cancers, which had not been treated yet?
Rarely, but after treatment, indeed, we find these cells in the peripheral blood.
So as an ongoing monitor, it is a reliable kind of test method after therapy.
We think that in many cases, we can very well monitor the further course of disease. And in some cases, we just can't, like in medicine, it's often. Okay.
Thank you.
So in December 2016, the MRI of the skull showed new additional brain metastasis. And therefore, she received from April to August 2017 whole brain irradiation. This led to a nice decrease in the peripheral blood, but we have no further observations now after she had this whole brain irradiation. And unfortunately, we assume that she didn't have any more therapy. So we think that the dynamics of the circulating tumor cells are a good parameter for personalized therapy decisions. It's non-invasive, and we have repeatedly now shown that without any intervention, it's reproducible. The cell numbers are the same in between 14 days, and it can be quantitative and can often detect the recurrence before it could be found in imaging, and we can identify time points at which imaging would be prudent, and we then recommend to do or to tightly monitor also the patient with imaging. And we think that maintrac helps to find personalized therapy.
Thank you, Professor Pachmann. Just before we do that, there was one question. And it's a common question, and do the numbers, the CETC numbers, correlate with the size of the tumor?
Yeah, no, definitively not. The numbers are dependent on the seeding quality of the tumor, and even small tumors can seed a lot of cells, and large tumors can retain the cells inside the tumor. So it does not correlate with the size of the tumor, or only marginally correlates. This has been shown also with other methods, that the circulating markers do not necessarily correlate with the size of the tumor.
Thank you very much. Well, like always, it's a fascinating topic, and hopefully the audience had a chance to appreciate that for their own clinic and for their own patients. And as always, if you further questions, please email us. We'll endeavor to answer the questions. We'll be interested to hear your comments and your feedbacks. But in the meantime, and we very much thank Professor Pachmann to continue lead the research and the clinical outcome studies with the maintrac method. So thank you very much.
Thank you. Goodbye.
Okay. You have a wonderful day. Thank you.
Same to you.